In asymptomatic individuals with severe primary mitral regurgitation, the optimal timing of intervention, it kind of remains controversial, but a paper in the November 1st issue of JACC offers some insights into what might be very informative. Now, this is the JACC November 1st issue, and to talk about this, I am with Dr. Milind Desai, who is an MD and of the Heart and Vascular Institute at the Cleveland Clinic, and a professor of medicine at the Cleveland Clinic Lerner College of Medicine at the Case Western Reserve University. Okay, so we're talking strain echocardiography and fractional capacity in asymptomatic. These are primary mitral regurgitation patients with preserved ejection fraction.
Yes.
So where does this come in? Where does the technology come in order to do what you're talking about?
Thank you very much for this. Basically, in valve disease, specifically in mitral regurgitation, specifically in primary mitral regurgitation, because of significant improvements in surgical techniques and our ability to do this minimally invasively at close to 0% mortality, the envelope of timing of surgery is being pushed more and more aggressively, where we are identifying patients that would benefit from an earlier surgical intervention. And so that's the basic fundamental principle behind our thought process is there something that we can look at even further, pushing the envelope in terms of timing for surgery.
So why has this been so controversial?
The fundamental notion of sending somebody for surgery when they are asymptomatic, that itself, to wrap your brain around that, tends to be difficult for folks. And the longer you have been in practice, the harder it is to accept the notion. And the older the patient are, maybe, it's just, you go to a doctor when you are sick, when you have symptoms, and then you have somebody telling me that I need heart surgery based on something that I have within my heart, which I'm not feeling anything about. And what if you're wrong? Or what if there's a side effect? So that's why this is still a hot ticket, a hot button issue. This is still controversial. But, the premise of this paper was, especially when it comes to mitral regurgitation, especially primary mitral regurgitation, it is accepted that pushing the envelope towards earlier surgery is the right thing to do. And what we wanted to do was to see, can we utilize newer technology? Can we utilize newer technology in echocardiography beyond left ventricular ejection fraction to identify such patients? So basically what we did was we had some basic data suggesting that stress echocardiography and using functional capacity may help risk stratify patients. So we have published that in the past, and what we wanted to do was to combine not just stress testing, but also the information, important information I might add, that you get on resting echocardiography beyond ejection fraction, and that is left ventricular global longitudinal strain. Basically what we did was we selected 737 patients with 3+ or more mitral regurgitation who had preserved EF. In this setting, in mitral regurgitation, definition of preserved EF is not greater than 50%, it is greater than 60%. Folks who had preserved EF and normal left ventricular dimensions, and they were asymptomatic. So basically what we did was, these were the folks that we studied observationally. These were, again, seen at the Cleveland Clinic. The physicians had decided how to manage them, including the decision to order stress testing in them. And basically what we did was we looked at their age and gender matched functional capacity on stress testing. We measured their standard echo parameters, including dimensions and our right ventricular systolic pressure and ejection fraction, etc. On top of that, what we also did was we measured their left ventricular global longitudinal strain basically using new available software. So these were older echoes, but using newer technology. And we measured them blinded away from all the other bias-causing clinical information. And then what we did was we looked at how strain that we measured and functional capacity that we had add in terms of prognostication in these patients. So basically, these patients were followed up for more than 8 years, and as one would expect in a low-risk mitral regurgitation population, the heart event rate was very low, about 9%. So over this long-term follow-up, about 60-something patients died. And again, our intention was not to study CHF endpoint or what have you. We wanted to study hard endpoints. Right. And what we show is that the global longitudinal strain provides independent prognostic value in terms of predicting future long-term death. So does functional capacity. And not only that, adding 1 + 1 provides synergistic value, where and both independently and synergistically increase their prognostic utility. Furthermore, not everybody that comes to Cleveland Clinic gets a heart surgery. Basically, about 65% of these patients underwent mitral valve surgery. Most of it was a repair. And what we also showed that basically that was associated with improved outcomes, along with increased RVSP that increased mortality, which all these things are known. RVSP, people know about it. So the newer factors were the strain and the functional capacity. More importantly, and then you may ask, okay, strain is a continuous variable. It's a number. How do you employ in clinical practice? So using some fancy statistical techniques, using quadratic spline analysis, etc., what we showed was if your strain, and strain typically is measured in negative numbers. So negative 25 is better than negative 21. So what we showed is if your absolute strain value is worse than negative 21, so negative 14, negative 15, negative 16, etc. And negative 21 was a cutoff at which it distinguished people who were at risk for mortality versus not at risk for mortality. Similarly, from a functional capacity perspective, it showed was if you achieved 100% of what is expected from your age and gender prediction, then life was good. Short of that, you had a slightly higher risk of increased mortality. And in all this, surgery was associated with improved outcomes.
I really like that in an accompanying editorial comment, Philippe Bertrand and Peter Vandervoort call it watchful waiting 2.0.
Yes.
I thought that was a good phrase.
Yeah, I think so.
They write the growing amount of evidence leaves no doubt regarding the importance of strain imaging in the assessment and risk stratification of asymptomatic severe primary MR.
And again, the important thing that needs to be, the important message is, strain is not there to replace echocardiography, but echo is a gross number, and echo has its set of limitations, and strain adds an element of increased sensitivity above and beyond echocardiography. So, I think, it's a newer technology that has potential in valvular disease.
Now, Dr. Desai, you do note in your paper that prospective evaluation is still needed in something like, is something like that actually planned or underway?
That's for, the short answer is yes, but in my opinion, it's not something that could and should be done by a single tertiary care center. I think this is something that needs to be done under the confines of a society with many centers and, coming to agreements about how to measure strain or rules of the game, and decision about surgery, etc. And so the answer is it should be done. Is it imminently being planned? At least I'm not planning that as of right now, but it would be a good thing to do, and this is the obvious next step.
The paper by Dr. Desai and colleagues is in the November 1st issue of JACC. Please look that up. For CardioSource World News and CardioSource World News Interventions, I'm Executive Editor Rick McGuire.